So Sasha was one of our fellows, and now she'll be my boss soon enough. She's actually really outstanding. She's a terrific speaker, and she is actually going to speak to you about HER2-positive disease. This is sort of laboratory focused, but also one of her clinic focus. So she's an emerging expert in this.
So I get to say that everyone who's spoken today is my mentor, so I'm super lucky. And that's me. So HER2-positive disease. This is about 20% of the breast cancers and is really driven by the overexpression of what we call an oncogene, or a receptor that really drives the growth of the cancer. And one of the most exciting findings in this is that we now have very targeted agents that can stop the driving of this receptor. And here are sort of the ones that are in practice today. I'm not sure if this is actually shining up there. So we have the trastuzumab, which is the one we've had for the longest time. This is Herceptin. When Nora and I can use the mouse. There we go. When Nora and everyone has been talking about antibodies, monoclonal antibodies, what this is these are made by your immune system, and so trastuzumab is a produced one of these that can bind to the receptor and prevent it from signaling. Pertuzumab is another of these monoclonal antibodies. It blocks between a different part of this receptor. Lapatinib is a different kind of therapy altogether. It's an oral medication that actually blocks the internal signaling of this receptor. So trastuzumab and pertuzumab block outside the cell. Lapatinib blocks inside the cell. It blocks the tyrosine kinase that signals down from there. And then we have the newest kid on the block, TDM1. And TDM1 is a combination therapy. It is a bind of trastuzumab, so of this monoclonal antibody, with a chemotherapy. And what it allows is binding to this HER2 receptor, so very targeted chemotherapy. But then the whole complex is brought into the cell, and the chemotherapy is released, particularly in these HER2-positive cells, to destroy the cells. So, very busy slide. You're going to notice lots of women's names. In HER2 breast cancer, we like to name trials after women. Famous women, in fact, Cleopatra. So this is really where we are today in our standard therapy for HER2 disease, and metastatic disease. At first line, we use trastuzumab, pertuzumab, so the combination of the two monoclonal antibodies with docetaxel. This is from the Cleopatra trial, which found that this was more effective than trastuzumab with docetaxel alone. Next line is TDM1. Remember, that's that combination therapy. And in the Amelia trial, this was shown to be more effective than lapatinib and capecitabine, and then lapatinib and capecitabine. But you'll notice with all of these that actually a clinical trial and really understanding how best to use this therapy by enrolling in a clinical trial really is the preferred method for metastatic disease. And the reason why is that we are still really trying to understand with HER2 disease. So this is actually in our adjuvant setting. Nora brought a similar slide to this, that we're really learning that highly lymphocyte-enriched tumors have better outcomes, and we particularly see this in triple-negative disease. However, if you look at triple-negative, which is here, and HER2-positive disease, they have very similar tumor immune infiltrates. However, when we looked at outcomes in HER2-positive disease, they're not as good. They don't see as much response with this immune infiltrate that we do in triple-negative disease. And the question really was why, and one of the answers to this is actually trastuzumab. While blocking the HER2 receptor and allowing us to really signal to prevent the tumor growing from that way, trastuzumab is also very much an immunogenic therapy, and so part of its role is in activating the immune system. This is a super busy slide. I'm an immunologist, so all these cells make me super happy. But basically what to say is, when you use these monoclonal antibodies, the immune system can see the tail portion of these, what we call the Fc receptor, and brings a lot more immune cells to that tumor. It sees that antibody, and that's a signal to our immune system. This is not right, we need to destroy this. And so we have found that trastuzumab, where if you remember the last slide, those lines were really close, we weren't seeing immune infiltrate, predicting a better prognosis. When we treat the patients with trastuzumab, we actually see that patients that have been treated with trastuzumab have a much better outcome because they have more of an immune infiltrate. And we actually have a very interesting trial that's now enrolling at the SCCA. It's the Sofia Trial, another woman's name. And this is margetuximab, which is another monoclonal antibody. But that Fc receptor, that pokey bit out, is actually designed to bring more immune cells and have more of an immune response. And we're looking at that as compared to trastuzumab with chemotherapy in metastatic disease. So Nora had talked about this as well. We have been looking at vaccines and vaccine therapy, again, to increase the immune recognition of HER2. And we've really seen that when we vaccinate patients, we can get more people to have an immune response to HER2. And we have seen that with trastuzumab alone, we only have about 40% of patients that develop this type 1 tumor-destructive immune response to the tumor. However, and so we call that a Th1 immune response. However, when we then treat with trastuzumab plus a vaccine, we now get many more patients developing this immune response. And the ones who even had it with trastuzumab, we enhance that. So what this is showing is, this is looking at our vaccine data in our metastatic patients. When we have patients who have a response just with trastuzumab, they tend to do the best. If we are able to augment that response with vaccination plus trastuzumab, we also see them doing quite well. And what we need to now figure out is this patient population that didn't develop an immune response to vaccination plus Herceptin, is there something else we can do to increase that immune response? Very busy slide. All of this to say TDM1 as well activates increased immune infiltrate in breast cancer. We've seen this in one small study that has just been coming out. And actually in mice, what they did is they looked at checkpoint inhibitors. And remember, those are what take the brakes off of the T cells. So TDM1 increases T cell infiltrate in the tumor. And we now have a study, KATE2, which is going to be coming to the SCCA, which will use TDM1 plus a checkpoint inhibitor. You bring those T cells to the tumor, and then you take off their brakes and let them work. And another new targeted agent that's more like papatinib, it's an oral agent that we found goes into the CNS, the brain, is called ONT380. And ONT380 is penetrates the brain, and we are going to be enrolling at the SCCA to use it with TDM1, again, to see if combination therapy can help. I have 2 more slides, and as always, usually my problem is I talk too fast, but PIK3CA, which I believe we've mentioned also in ER positive, but there are some mutations in this that are found more in HER2 breast cancer, and these mutations basically prevent, even if you're blocking this receptor at the top, they prevent signaling, the correct signaling farther down. And we found with these mutations that using the mTOR inhibitor, this everolimus that Hannah Linden brought up with ER-positive breast cancer, can also improve outcome in HER2-positive breast cancer. And then finally, we all know we have about 10% of our patients who have estrogen-positive and HER2-positive disease. And in these patients, the 2 receptors work together, have crosstalk together, and we need to treat both of these in order to really effectively treat with endocrine therapy. So thank you guys very, very much. And